All right, let's start with cardiovascular. Okay. So cardiovascular embryology. So what do we have here? We have heart morphogenesis as the first functional organ in the vertebrate are embryos, beat spontaneously by week 4. So 4 week is important, right? We have cardiac looping. That's the primary tube loops to establish left-right polarity. Because of the week 4 of development, defect in the left-right dynin involved in the left-right asymmetry can lead to dextrocardia. So defect in dynin leads to dextrocardia seen in Cartagena syndrome. What is dynin and kinesin, right? What are these two for? So dynin, it's a retrograde transport, and kinesin is an anterograde transport. And what is the mnemonic for these two? So the way I think about it as, so when you die, you go down, right? Like you're buried in the earth. So you're retrograde. So die, you go retrograde down. So we are living above this right now, right? But when you die, you go down, right? So that is the dynin. It's a retrograde transport. And if the dynin is retrograde, the other guy has to be the intergrade. So kinesin is going to be intergrade. So that is my mnemonic. But if you have any better one, that's also good. Then you have moving on with the separation of the chambers with the atria. Atria is the, let's look at with the picture here. So you have development of septum primum that grows toward the endocardial cushion, narrowing the ostium primum. Okay, looking at picture here, septum primum is growing towards these endocardial cushions, right? And narrowing the ostium primum. Simple. Second thing, ostium secundum forms in the septum primum due to cell death. And that's important due to apoptosis. This happens due to by perforation of the septum primum through apoptosis, cell death, or programmed cell death, in other words, right? So what do we have here? So we have the second one is septum secundum starts forming down in the septum primum due to cell death, and septum primum is still growing towards that endocardial cushion. So we still have this ostium primum, but because of cell death, we have just developed the ostium secundum, and due to cell death in the ostium primum. So if you just, let's say this is septum primum, let's just call this septum primum, which is going towards, let's say, endocardial cushion. Well, while it was going there, so you have the first thing that it is trying to close is the ostium primum, but while it was going there, it itself had some cell death, programmed cell death in the septum primum that open up a new pathway. We call it ostium secundum. Ostium means an opening. Septum is a septum. So remember the vocab here. Ostium secundum and ostium primum. Two openings. Right? And the third thing is you have septum secundum develops on the right side of the septum primum, and ostium secundum maintains the right to left shunt. So they're saying you have now a new thing, which is septum secundum, which starts on the side of septum primum and starts growing towards this trying to close this ostium secundum and going towards ostium secundum, and this would give you right to left shunt. So if you look in this picture, wait, let me erase this. Oh, what? So if you look here, the ostium primum, which was here, right, it has been closed. So we have no more ostium primum. All we are dealing with now at this stage is this opening. This opening is right here again. We will be trying to close this by a new septum. We called it septum secundum. So this guy is going to go down and it's going to try to close this. But there is this is the, now ostium secundum is the one which is going as which is giving us at this point right to left shunt, right? Wait, let's erase this, right to left shunt. Moving on with the 4 point, that's the ostium septum secundum expands and cover most of the ostium secundum. The residual foramen is going to be called as foramen ovale. So they're saying again that this septum is going to grow towards it has grown enough that now we just have a very small opening left, and that small opening, instead of calling ostium secundum, now we're calling it foramen ovale because it's a very small opening. Here it's called foramen ovale because it is formed by septum secundum going towards the endocardial cushions or towards the other septum secundum, which is they're growing towards each other. Now finally, in the 5th picture, is the remaining portion of the primum. Septum primum forms the one-way valve of the foramen ovale. Okay, so here's what it is. Is this septum primum, right? This septum primum, now it forms a one-way valve with the one-way valve of the foramen ovale, and foramen ovale was the remaining portion, right? And that's all for the atria. Recalling, now just quickly recall. So the primum, give me 1 second. Okay, yeah. So the primum, septum primum is going to go and start developing towards the endocardial cushion while it is on way. And why is it trying to close that? Because it's trying to close this opening, which we call ostium primum. While it was going there, there was an apoptosis of itself. Programmed cell death, apoptosis, cell death of the primum, septum primum itself, that formed another opening. We call that secondum, primum secundum, right? And now we have secundum to deal with, because the primum will eventually close, right? Now we have secundum to deal with. That secundum, to close this ostium secundum right here, we developed another septum from top. We called it septum secundum, which is going to eventually come and down and close this out. But while it does close out, there's still an opening here, and that opening will be called as ostium. That will be called as foramen ovale, opening ovale, foramen ovale. Moving here, you can see this did close down this ostium secundum, but there is an opening. Still small flap of opening. We call it foramen ovale. That flap of opening is formed by two things now. One thing is septum secundum, and one thing is primum, septum primum. A flap is formed called as foramen ovale. Okay, and that's all for this atria. Now, looking at the 6th point here, it says septum primum closes against septum secundum, stealing the foramen ovale soon after birth by increase in left atrial pressure and decrease in right atrial pressure. So there's a simple thing again. You have the septum secundum here, and you have the septum primum, endocardial cushion, and just atria. So they're saying now that after birth, what's going to happen is your left atrial pressure is going to increase. When the left atrial pressure is going to increase, that pressure is going to push on this primum, septum primum, and this will close this flap. And when you close the flap, there will be no more fluid coming from there's no more from right to left shunt. Okay, and now the 7th point is septum secundum and septum primum fuse during infancy, early childhood, forming an atrial septum. Now, because they're now fused, now the whole thing is known as atrial septum. Now, parent foramen whale, what is that? It is caused by the failure of the primums, septum primum and septum secundum, to fuse after the birth. Most are left untreated. Can lead to paradoxical emboli. What is paradoxical emboli? Let's read about it. It is the venous thromboembolic entering the systemic arterial circulation through right to left shunt. Can occur in atrial septal defect as well. So simple things, very high yield though. What is this? So they're saying if you have, let's say this is inferior vena cava, right? Inferior vena cava. If you have any thrombus going into the right atrium and to the right ventricle, normally what happens is, and in a normal person, from the blood goes from right atrium to right ventricle into the lungs, right? And in the lungs, that small clot is gonna go in, and it starts. It goes into the lung and does not come out of the lung into the left atrium. And from left atrium, we're looking at left ventricle, and eventually looking at circulation, or even going to the brain, causing stroke, or anything. It can go and cause stroke. Not only stroke, but GI. It can cause any ischemia of the GI. Anything can happen as soon as you are in systemic circulation. But now the question arises that because these small thromboembolic these thromboembolisms, they're very small, and they will get lodged within the lung, and they will never come out of the lung. So in normal patient, you will never see someone who has DVT, deviant thrombosis, and emboli comes up, and an emboli goes into the right atrium, the right ventricle, goes into the lungs, and goes into the left atrium, left ventricle, and then systemic circulation. It's not going to happen because it's going to stop right here. It's going to cause PE, pulmonary embolism. It's going to block right here. But now here the problem is, if you have opening, which is foramen whale, an opening from right atrium to left atrium, you have an opening. So as soon as some clot comes in here, it's going to go straight from the foramen whale to the left atrium. From left atrium, it has to go straight into left ventricle to systemic circulation, causing stroke. Or if you have atrial septal defect, as they have mentioned, you have atrial, the whole septum is out. So still you can have this. The emboli can go from right atrium to left atrium and going into the left ventricle and eventually circulation, right? So that's why they call it paradoxical. That normally doesn't happen, but paradoxically, you don't think about it, but it can happen if someone has their foramen whale was patent, and you don't see it enough. And I mean, it's there, but it's not symptomatic unless something happens. So they're saying, okay, fuse after birth but left untreated can lead to paradoxical emboli if you leave it untreated, right? Let me read one more time so it makes sense. So parent foramen whale is caused by failure of the septum primum secundum to fuse after birth. So there is no fusion. When there is no fusion, which are left untreated, they can lead to paradoxical emboli, which is venous thromboembolism entering systemic arterial circulation to right to left shunt, and can occur in ASD as well. So this is all about PFOs, which are parent foramen whale. Moving on with the next one, which is called hard morphologies, hard morphogenesis of ventricles. In the ventricles, we have muscular interventricular septum forms. So muscular interventricular, I'm going to highlight here, is this one. So muscular interventricular forms, opening is called interventricular foramen. Okay, we have an opening. We see an opening here, and this opening is called somebody was asking for PFO versus VSD. We're talking about VSD right now. We'll see how they're different. Okay. and I'll explain that. So we have a muscular interventricular septum here, and interventricular foramen is here, right? This is foramen. Opening within the ventricles is called interventricular foramen. Now let's look at the second point. Second says our aorticopulmonary septum rotates and fuses with the muscular ventricular septum to form membranous interventricular septum, closing the interventricular foramen. So this is our aorticopulmonary septum, as it's stated by right here, right? Aorticopulmonary septum. So this would rotate, this aorticopulmonary septum would rotate, and it will fuse with this muscular one, and it would eventually close up this interventricular foramen. Again, aorticopulmonary septum rotates and fuses with the muscular. So this guy is going to let's say this guy, aorticopulmonary septum, is going to fuse with this, will close out this guy, which is interventricular foramen. Simple, right? Now growth of endocardial cushions would separate. So they haven't drawn the endocardial cushions, but here let me change color. Endocardial cushions are supposed to be between atria and ventricle. So here's, let's say, the endocardial cushions. So what are they saying is they're saying they are going to grow towards each other. Endocardial cushions, they separate the atria and the ventricle, contribute to both atrial separation and membranous portion of the interventricular septum. So they're going to get closer to each other and close off this atria versus ventricle, one thing. On top of that, they are also separate and they contribute to both atrial separation and membranous portion of the interventricular septum. So what is the membranous portion? Right here, membranous interventricular septum. This is a portion of the interventricular septum which is membranous. It's called membranous interventricular septum. Okay, so that's what we have. So what is VSD now? VSD, it is a ventricular septal defect, is the most common congenital anomaly. Usually occurs in the membranous septum. So they're saying right here, it's going to occur most likely the top portion of the ventricle, which is the membranous septum, and it is right there. Now, other thing they haven't mentioned is the rotation here. Let's also talk about this one. So rotates. The aorticopulmonary septum rotates, right? So normal is the spiral. It rotates. If you look here, it is spiraling. It's a spiraling of the aorticopulmonary septum that results in from the right ventricle you would have coming out the pulmonary vasculature, and from the left ventricle you will have the aorta coming out of the left ventricle. That's due to spiraling. So if you don't have the spiraling, if the spiraling does not occur, what's going to happen is that you would have, it's called linear aorticopulmonary rotation instead of spiraling rotation that would lead to TGA, transpositioning, and we will talk about that in pathology, but that's going to lead to transpositioning of the great vessels, in which case from right ventricle you will have aorta, and from left ventricle you will have pulmonary veins because of the transpositioning of the great vessels. Okay, so that's what we have for that. Looking at the next one is the outflow tract formation. You have the neural crest cell migration, which leads to truncal and bulbar ridges that spiral and fuse to form an aorticopulmonary septum, which leads to ascending aorta and pulmonary trunk. Again, aorticopulmonary septum is eventually which cell has to migrate to form that aorticopulmonary septum? Neural crest cells will migrate, cause the spiraling and fusion of the aorticopulmonary septum, right? And that's important. Neural crest cells for aortopulmonary septum, leading to formation of eventually ascending aorta and the pulmonary trunk, high yield. Okay, conotruncal abnormalities associated with the failure of the neurocrest cells to migrate are transposition of great vessels, high yield, TGA, which we just talked about up top, tetralogy of Fallot, high yield, TOF, and persistent truncus arteriosus, arteriosus, PTA. Okay, now let's look at the valve development. What is the valve development? Valve developments are aorticopulmonary, aortic, and the pulmonary are derived from those endocardial cushions that we were talking about, which were separating the atria with the from the ventricles, while the mitral and tricuspid are derived from fused endocardial cushions of the AV canal. So endocardial cushions are the outflow tract, and all endocardial cushion of the AV canal. But important thing is valve development all occurred by endocardial cushions. So valvular abnormalities could be stenotic, regurgitant, atretic, which is tricuspid atresia, or displaced, abstinent normally. Right. Moving on to the arches. Okay, arches. Aortic arch derivative. The first one is the first arch is maximal. Maximal is the maxillary artery, part of the maxillary artery, right? Second is the second stapedial. S for second, S for stapedial. If you can remember high-eyed, great. Third is 3 letters is C. C is the third letter, so common carotid artery. And you can see it here, common carotid artery, which is and then the proximal part of internal carotid, and some part of external carotid. Actually, just the internal carotid. So these two things are C, which is third. Fourth is the on the left side aortic arch. On the right side, we have the proximal part of the right subclavian artery. 4 limbs equals systemic. 4 limbs equals systemic. Now there is no fifth, so there's sixth. This is high yield. Why? Because it's going to give rise to proximal portion of the pulmonary arteries on the left side and ductus arteriosus, high yield. So sixth is giving rise to the ductus arteriosus. Sixth arch equals pulmonary, and pulmonary to systemic shunts, ductus arteriosus. So 6 give rise to ductus arteriosus. Okay, so that's what we have for aortic arch derivatives. Then we have the next one, which is called heart embryology. Heart embryology is very simple. What do we have? So the first thing we have is, so let's look at here. Truncus arteriosus. Truncus arteriosus. Let's actually draw truncus arteriosus, okay? So this is going to be our truncus arteriosus. This is truncus arteriosus, right? So truncus arteriosus gives rise to ascending aorta and pulmonary trunk. So it's truncus arteriosus giving rise to two things: ascending aorta and pulmonary trunk. That's truncus arteriosus. And these two things are just the things which are coming out of the heart. So truncus arteriosus give rise to something that comes out of the heart, which is ascending aorta and the pulmonary trunk. Now we have the bulbus cordis. Bulbus cordis. It is a smooth part of the left and right ventricle. So we have, this is the ventricle. It is the smooth part of that ventricle. Remember the smooth part. Then you have the primitive ventricle. Whenever you see a primitive here in this embryology, primitive always means something which is your trabeculated part. Trabeculated part. Okay, so primitive ventricle, we're talking about trabeculated part of the left and right ventricle. So we have bulbous cordis we have, and then we would have a trabeculated part of the ventricle, which is going to be your primitive ventricle. Primitive ventricle. This is trabeculated. And then you have this, on top of this primitive ventricle, what are you going to have is you're going to have primitive atria. So you see all these trabeculated parts that are nearby each other. So they're the trabeculated part of the left and right atria. Okay, and then what do we have? After the primitive atria, we have sinus venosus. So here's going to be your sinus venosus. Sinus venosus. So sinus venosus, so we have a left horn of sinus venosus and a right horn of sinus venosus. So here's the left horn of sinus venosus, and this is going to be the right horn of sinus venosus. This sinus venosus, the left horn, gives rise to the coronary sinus, CS, while the right horn gives the smooth part of this ventricle. So this is the smooth part of the ventricle, right? Smooth part of the right, my bad, not ventricle, atrium. Smooth part of atrium is due to right sinus venosus. Okay. Endocardial cushions. Endocardial cushions are the atrial septum, membranous interventricular septum, AV, semi. So all the valves, we know that. On top of that, we're talking about atrial septum and membranous interventricular septum and all the valves, right? Now, high yield point is about the veins. Right common cardinal vein and right anterior cardinal vein, they are going to form superior vena cava. So what are we looking at? We are saying that, let's just do it here. So this was about coronary sinus, and this is all about your superior right sinus venosus is going to give you superior vena cava plus inferior vena cava. Now, specifically, superior vena cava is going to come from your right cardinal vein, and inferior vena cava will be the other cardinal veins, and we will read that above. So right common cardinal vein, right anterior cardinal. So all the right ones, no matter you call it anterior, common, all the right ones are the cardinal vein, are giving the superior vena cava. So they're giving rise to SVC, high yield. All the other ones, not the right ones, the posterior, the cardinal, subcardinal, anything with the posterior one is going to give you the IVC. So other cardinal veins, or you can also write posterior cardinal veins, will give rise to IVC. So who's giving rise to high yield is high yield point, okay? Who's giving rise to superior vena cava? The right cardinal veins. Could be right, could be two things, right? Right is the common, right common, and right anterior. Who's giving rise to IVC? The posterior. That's important. Now, who's giving the smooth part of the left atrium, which we left here, right? And that is given by the primitive pulmonary vein. Primitive. This is only exclusion to that mnemonic that primitive is trabeculated, because this vein is not supposed to be trabeculated, right? So primitive is the left atrium, which is right here. Okay, let's also look at, I guess, let's just recall this and move it on. Okay, so we have the truncus arteriosus. Okay, this picture, let me do this. Truncus arteriosus. Truncus arteriosus gives rise to ascending aorta, pulmonary trunk. Then this after truncus arteriosus, we have the bulbus cordis, which is your smooth part of the ventricle. Both ventricles we're talking about. Primitive ventricle is giving you the trabeculated part of both ventricles, and here's the endocardial cushion, which gives off the valves. On top of that, it gives off these two things, which is ASD, atrial septals and interventricular membranous septums, and that is your endocardial cushion. On top of that, you have the trabeculated part of the atrium. This is given by primitive atrium, the left and right, but the smooth part on the right side is given by the sinus venosus, SV. Sinus venosus gives off the smooth part of your right right atrium. And who's giving the smooth part of the left atrium? That is done by primitive pulmonary vein, right? If you recall, the left atrium, who enters the left atrium? So left atrium, this is left atrium, right? So pulmonary vein enters left atrium. So for sure, that's the one which gives the small part of the left atrium. Okay, and now talking about the veins, one more thing for the left one. So we talked about right sinus venosus. Left sinus venosus gives rise to coronary sinus, which is right here, coronary sinus. Now we talked about how superior vena cava and inferior vena cava are formed. They are formed by this. Superior vena cava is formed by the all right cardinal veins, while inferior vena cava is formed by all posterior cardinal veins. And that's all for this heart embryogenesis or embryology. Okay, moving on with fetal circulation. Fetal circulation is very simple, very high yield. What do we have? We have here you go. So blood in the umbilical vein has about PO2 of 30 mmHg and 80% saturated with O2. Umbilical arteries have low O2 saturation. There are three important chunks. Blood enters the fetus through the umbilical vein. Is right here that the blood enters through umbilical vein from placenta to umbilical vein to the fetus, right? Umbilical vein is conducted via ductus venosus into IVC. If you look here, via ductus, so it is going to bypass the liver. Why does it bypass liver? Because liver is a dense organ. If you go there, you're going to take a lot of your oxygen, which you don't want, and you want to give all that oxygen to more tissues, for example, the cardiac and also in the systemic circulation, the brain, and everything else to develop more. So we want to block this thing. How do we block it in the fetus? We block it by there's another pathway, there's another highway, you can call it. It's called ductus venosus, which takes out the blood and goes straight into the IVC, inferior vena cava, bypassing hepatic circulation. Most of highly oxygenated blood reaching the heart via the IVCs directly through the foramen veil into the left atrium. So it comes here, goes into the right atrium. So instead that most of it goes into the right ventricle in normal people, it goes through this foramen veil and towards the left atrium. So we are now in the left atrium now. And from left atrium, guess what? It goes into the left ventricle. From left ventricle, it goes out in aorta. Okay. Foramen veil is used here. Now the next thing is the deoxygenated blood from the SVC passes through the RA to RV. So deoxygenated blood from SVC, superior vena cava, passes through the RA to RV. So they're saying, in other words, that IVC, inferior vena cava, goes straight up like this. Let me change color. Maybe that would be a better way. So IVC comes and goes here straight up. But the SVC, instead of going down, because it's coming from top, so it goes into right ventricle. From right ventricle, because we need some fluid in the lungs, right? So it goes into the lungs. So from SVC, it goes into the lungs, main bronchus, main pulmonary artery, and through the lung. Instead of going to the lung, from there, it uses the another opening called ductus arteriosus. That from ductus arteriosus is goes into this aorta, right? It goes into aorta, and from aorta it just goes down to descending aorta, and shunt is due to high. From here it goes just down, and the shunt is due to high fetal pulmonary artery resistance. They're saying, why does this happen? It's happened because you have a very high resistance here and here. So the blood, so let me block these out. So the resistance here and here. So when the blood is coming, instead of going into the normal pathway, because there's so much resistance, it just goes into this ductus arteriosus. So what's going to happen at birth? So infant takes a breath. It decreases that pulmonary resistance, pulmonary vasculature resistance, and that causes increase in left atrial pressure versus the right atrial pressure. This leads to foramen veil closes now because you have more pressure. You have more pressure in the left atrium, so that foramen veil that we made will close because the pressure is going to push on the primum, septum primum, and close this flap, and the foramen veil will close, which we'll call now fossa valis. Increase in O2 from the respiration and decrease in prostaglandins. Two things: increase O2 from respirations and decrease in prostaglandins, because the placenta would separate. After birth, what do? Cut the umbilical cord. Placenta separates. When the placenta separates, you no more have prostaglandins. So when you don't have any more prostaglandins, it's going to lead to closure of the ductus arteriosus, which is right here. So who's maintaining important high yield? Who's maintaining ductus arteriosus? O2 and prostaglandins from placenta. So when you don't have, when you have increase in O2, because now you're starting respiration on your own, increase O2, and you don't have any more prostaglandins, it's going to close this ductus arteriosus. Now, if that doesn't close, then you can give NSAIDs, which is indomethacin, ibuprofen, or acetaminophen, help close that parent ductus arteriosus, which leads to formation of ligamentum arteriosum, which is the remnant of ductus arteriosus. Endomethacin ends the PDA. And again, what is the NSAID or endomethacin doing? They're just inhibiting that same prostaglandins, which normally, when you have this placenta cut down, you're gonna not have those prostaglandins. So same thing here. We're giving prostaglandin, we are giving NSAIDs to inhibit those prostaglandins to close this ductus arteriosus. Okay, so PDE1 and E2 keeps PDA open. Prostaglandins are the ones which keep the PDA open. Now let's just recall some high yield points and move on to the next one. What are the high yield points? High yield point is ductus arteriosus comes off from the sixth aortic arch. It is derived from sixth aortic arch. There are three shunts: ductus venosus, foramen veil, ductus arteriosus. What is the most oxygenated blood in the where's the most oxygenated blood here? The most oxygenated blood is going to be in your umbilical vein. So umbilical vein has most oxygenation because it's coming straight off placenta. What is the most very low to most deoxygenated within this fetal circulation? And that is going to be your right here, which is your inferior vena cava, and the highest is your umbilical vein. Okay, what else we might have? Yeah, that's pretty much all extra. Moving on with this one, and this is going to be the last one before we hit anatomy. So what are the fetal postnatal derivatives? So ductus arteriosus. Ductus arteriosus is going to give you, so how about this? Just think about arteriosus, arteriosum, venosus, venosum, right? And ductus in the fetal structure is going to give you ligamentum, meaning ligament. So ductus arteriosus, ductus means ligament, so ligamentum arteriosum. Ductus means ligament, ligamentum venus means venosum. Excuse me. Okay. And for the ductus arteriosus, what do we have? It is near the left reculolaryngeal nerve. Why is that important? Because that is important when if you were to give in a post cardiac surgery. When you're doing a cardiac surgery, you can't give nick, meaning you could specifically cut it down a little bit, like just have a little nick to this left reculolaryngeal nerve, which is very near the ductus arteriosus, ligament arteriosum. In the cardiac surgery, you can give a nick to it, and this will lead to hoarseness as a complication. So that's why that is important. Okay. Foramen ovale is the fossa vallis. Allantois leads to urachus, which leads to median umbilical ligament. Umbilical arteries can give you medial umbilical ligament. So median, allantois, umbilical, medial umbilical ligament. Umbilical vein, on the other hand, is the ligamentum teres hepatis, which is the round ligament containing the falciform ligament. That's all for the fetal postnatal derivatives. Moving on with the